this lecture on cardiovascular physiology, focusing on the heart. So this is the second video of part uno. And what we're going to do for the next several slides is just go through everything that's happening during a cardiac cycle um, with some different diagrams. These actually I should credit to Dr. Ian Ward, who then was just Ian Ward PAC. He made these as helps when he was a student. This was his study guide, but he showed them to me and we decided to incorporate them into this lecture. So, atrial contraction, the atria contract. Let's talk about what happens during that time. First, and these are in a certain order for each of the events, but the events may be slightly different in order from what's on this slide. The atria depolarize. Okay, so there is a depolarization at the sinoatrial nerve that causes the atria to depolarize and the muscles in the atrium to contract. The AV valves between the atria and the ventricles are open, and they have been open. The semilunar valves are closed. On the EKG, we see this as the P wave, which represents atrial depolarization. So it's electrical signals that we can detect on the surface of the skin as a result of the electrical activity in the atria depolarizing. In terms of pressure curves, if you look at the pressure in the atrium, there's a little bit of an increase in pressure. There's a little bit of increase in pressure in the jugular vein, so venous pressure, because it's transmitted backwards. There is no valve between the vena cava and the right atrium, and that is called the A wave. It also, there's a little increase in pressure in the atria, so the left atrium. And we could look at that on the Wiggers diagram. In fact, let's go back and see if it's on. It's not on this one. It is on this one. So we have the A wave, this slight bump during atrial contraction. The ventricular volume increases after atrial contraction. So at the end of atrial contraction, the ventricles have reached something called end diastolic volume. It's about 120 milliliters in a normal heart, and it is the ventricular preload. End diastolic pressure and volume contribute to preload. Sometimes in an abnormal heart with stiff non-compliant ventricles, we might hear S4. And it's important to know that most ventricular filling is just due to gravity. It's due to blood flowing by gravity out of the atrium into the ventricle on both sides. But there is about a 10% contribution of atrial contraction to ventricular filling, which is important when we talk about problems like atrial fibrillation. If the atria are not functional and aren't contracting, we lose a little bit of ventricular filling, which can decrease cardiac output and be a real problem if the heartbeat is fast, which it sometimes is in atrial fibrillation. After atrial contraction, we get ventricular contraction. So the events are that the ventricles are depolarizing, and that as they begin to depolarize and contract, and you will remember that there is a little delay in that signal when it goes through the AV node and the conduction system. But when it begins to contract, there is an increase in pressure in the ventricles because the valves are closed. All the valves are closed. The closure of the mitral and tricuspid valves resulted in S1, or the first heart sound. The mitral and tricuspid valves close very close together in time, and so you can't ever hear two separate sounds in S1 unless there's something abnormal going on. So S1 has a single component, primarily mitral valve closure. The papillary muscles in the left ventricle and the chordae tendineae, and there are also papillary muscles in the right ventricle, keep the AV valves from prolapsing, meaning they keep the AV valves from opening backwards when the pressure in the ventricle is high. On the EKG, ventricular polarization results in what we call the QRS segment. Ventricular pressure rises rapidly. There may be a little bit of an increase in right atrial pressure or jugular venous pressure because the tricuspid valve kind of bulges back up into the atrium. Ventricular volume initially remains the same. That's that isovolumetric or isovolumic phase of ventricular contraction. And this is the time when oxygen demand in the myocardium is highest. As ventricular contraction continues, the valves open, the semilunar valves to the big arteries, the pulmonary artery and the aorta, they open. And now we have ejection, where we have rapid movement of blood out of the ventricles into the vessels. Initially, it's very fast, and then it slows down. And as this is happening, the ventricles are starting to repolarize. There shouldn't be any heart sounds during ejection, but when you have abnormalities in the pulmonic or aortic valves that cause turbulent blood flow, you can get murmurs. So the murmurs that occur in systole during ejection, they're sometimes called ejection murmurs, and they are generated through turbulent blood flow at either the pulmonic valve or the aortic valve. On the EKG, first we have the ST segment and then the T wave, and the T wave represents ventricular repolarization. And in terms of the pressure waves, the aorta achieves maximum systolic blood pressure. The pressure in the ventricles starts high and decreases. Blood begins to flow in. Blood is flowing into the left atrium from the pulmonary veins and to the right atrium from the vena cava. But ventricular pressures are starting to fall as the blood leaves and the ventricles are starting to repolarize. And volume decreases initially rapidly, then less sharply, and then we come to diastole, so relaxation and filling. So the aortic and pulmonic valves close when the pressure in the aorta and the pulmonary artery exceed the pressure in the left ventricle and the right ventricle. And this is that period of isovolumetric relaxation where the ventricular muscles are relaxing, the valves are closed, the AV valves open, the ventricles are filling. The closure of the aortic and the pulmonic valves causes the second heart sound. And the second heart sound can have two components. There is a fraction of a second differential between the closure of the aortic and pulmonic valves that in some cases can cause what we call a split S2, and you'll learn about that in H&P. It is possible to hear a third heart sound during the rapid filling during diastole of the ventricles. So a lot of blood was in the atria when the AV valves opened. And so you have pretty rapid filling initially, and that can twang those chordae tendineae and cause an S3. On the EKG, it's flat. We're between the T wave and the P wave. And in pressure curves, you get rising pressure, or it's pretty constant pressure in the left atrium. There's venous return from the lungs, but it's flowing straight into the ventricle. When those valves open, the jugular pressure falls, and then starts to rise slowly as the atria fill. Ventricular pressure is low, and then it starts to slowly rise as the ventricle fills. The closure of the valves, the aortic and pulmonic valves that cause S2, can result in a small kind of bump, notch, in the aortic and pulmonary artery pressures, which, if you are very subtle, you may feel when you're checking a carotid artery. When the ventricle is empty, that's the end systolic volume, and that's about 50 ml in a normal heart. Once the AV valves open, as I said, ventricular volume goes up pretty quickly, then more slowly, about 90% of it occurring before atrial contraction, which contributes that extra 10%. And again, our Wiggers diagram with not all, but most of those events. So P wave followed by atrial depolarization and atrial contraction. QRS complex with followed by ventricular depolarization, ventricular contraction, initially with the closure of the AV valves resulting in S1 before the opening of the the semilunar valves, the pulmonic and aortic valves. You have this period of rapid rise in ventricular pressure called isovolumic contraction. You have ejection when the valve opens. Once the pressure in the aorta exceeds the pressure in the left ventricle, we have closure of the semilunar valves resulting in S2 and a rapid decrease of pressure in the ventricle. It has reached end diastolic volume until the AV valves open and the ventricle starts to fill again here. So at the very beginning, I said that it's all about pressures and flow, but that it's also about electrophysiology. So what we're going to talk about for the next several slides, and actually the rest of this presentation, is the heart's electrical activity. The SA node, the sinoatrial node, as I've said before, is the pacemaker of the heart. And it has this characteristic, this quality that we call automaticity, in that it automatically depolarizes. So in a pacemaker cell, which is a specialized cardiac muscle cell, cardiac myocyte, there are calcium channels that kind of have a leak that allow the influx of calcium, bringing the membrane potential to threshold slowly, always. Now, if there is input from the sympathetic arm of the autonomic nervous system, this slope becomes a little steeper and the rate is a little faster, and vice versa. Parasympathetic input decreases this slope a little bit, slowing the rate. But the sinoatrial rate is more or less 60 to 100. Sinus rhythm we define as 60 to 100. There are times when the sinoatrial node is unable to function and other pacemakers pick up, but each at a slower rate. So if the sinoatrial node isn't functioning, perhaps the AV node takes over, and that rate would be maybe 40 to 60, maybe even a little slower, maybe 30 to 50. If that gives out, you have cardiac myocytes in the His bundle that may take over. You can tell if you have an ectopic or abnormal pacemaker by forces on the electrical tracing that we call the electrocardiogram. I'm not going to make you learn all the details, but basically there are different channels in cardiac pacemaker cells. There's something called funny sodium channels. There are a couple kinds of calcium channels, transient and long acting. And then we have potassium channels. So you have some of the same channels and some channels that are different than the ones that we've talked about, for instance, in the nervous system. One of the very important ones is the transient calcium channels that allow for a leaking of calcium into the cell, bringing the cell membrane potential to threshold, allowing for the generation of an action potential, which is completed by long-lasting calcium channels and potassium channels. I'm sorry, long-acting calcium channels. Subsequently, the calcium channels open, allowing and the potassium channels open, the calcium channels close, and you get repolarization and hyperpolarization, and then those transient calcium channels open again. When you get sympathetic stimulation, that can either be norepinephrine through sympathetic fibers, or vagal stimulation, which would be acetylcholine from the vagus nerve, you get changes in heart rate. So sympathetic stimulation speeds up the action of the sinus node, and vagal stimulation slows it down. And as you can see here, it's a change in the slope of that potential that is bringing the membrane potential from its equilibrium potential to threshold, allowing for an action potential. Now, the action potentials in cardiac myocytes are a little bit different, and they are quite different from the action potentials of neurons. It is a long action potential with a plateau, and again, that has to do with the fact that we have different ion channels. We have funny sodium channels instead of the fast sodium channels that we see in skeletal muscle. And the slow calcium channels, and those calcium channels remain open much longer than the sodium channels in skeletal muscle and neurons. So depolarization just takes longer. And as with all cells that generate action potentials, there is a refractory period. So during an action potential and for some period of time after the action potential, you can't get another action potential. So you don't get what's called re-excitation. The muscle contraction begins right after the action potential begins and ends right after the action potential ends. milliseconds. And it lasts about a fifth of a second in the atria and about a third of a second in the ventricles. And so here is the cardiac myocyte action potential. Funny calcium channels, funny sodium channels, slow calcium channels, this long action potential with a delay lasting here a fifth of a second. So the contraction starts is right after the action potential starts, and it ends shortly after the action potential ends. You can't get a new action potential during this or for some period of time after it. This is an illustration of how those action potentials contribute to the EKG. So the sinoatrial node creates the pacemaker action potential, which then triggers the atrial muscle cells to contract. The signal reaches the AV node, is stopped by this fibrous material between the atria and ventricles, but proceeds through the AV node, through the His bundle, here called the common bundle, and the bundle branches out to the Purkinje fibers, which take it to the ventricular muscle. The P wave represents the electrical activity of atrial depolarization. The PR interval represents atrial repolarization. The QRS complex represents ventricular depolarization, but it's picking up the signals that are being sent through the Purkinje fibers and so forth. That contraction results in a kind of a long action potential during which the ventricles are repolarizing, and the T wave here represents ventricular repolarization. And then there's a refractory period, so there's going to be a little bit of time before the next P wave. So, to repeat, the SA node generates the action potential, which spreads to the atrial myocytes, causing atrial contraction. When it reaches the AV node, there's a brief delay of about a tenth of a second as that impulse passes down the His bundle, the His bundle, the bundle branches, the Purkinje fibers, and then to the ventricles. And then the ventricles contract. So ventricular contraction occurs after atrial contraction under normal circumstances. And what we call the EKG or the ECG, the electrocardiogram, is a way of measuring the summed electrical activity of the heart as those forces, electrical forces and currents, are transmitted from the heart to the skin where we measure them. So let's talk a little bit about the EKG. This is not about reading EKGs. This is about understanding EKGs. This is a single cardiac cycle on EKG. It begins with a P wave, and we're measuring millivolts. So with a baseline of 0 millivolts, the P wave is just a little, okay? Tenth of a millivolt. It's a small impulse that represents depolarization of the atrial myocytes and is followed by atrial contraction. Then the atria repolarize, and we get to the QRS complex, which is a representation of the direction and amplitude of the electrical forces as the action potential spreads through the ventricles, causing ventricular contraction. So we have the QRS complex followed by ventricular contraction and then ventricular repolarization, which is the T wave. And this is all from about here to about here, the ventricles are contracting. So the T wave is as the ventricles are just about to start to relax. The ventricles are repolarizing. So sometimes these complexes are at normal intervals. This is, let's say, 300, 150, 100. This is about 75 beats a minute. Sometimes they're really fast. This is at about 130 beats a minute. Sometimes really slow. This is a little slower than 50 beats per minute. These are all regular. Sometimes they're quite irregular. Okay. So as with all cells where there's electrical activity, cardiac myocytes have a negative charge under normal circumstances at rest on the inside of the cell membrane. When a action potential is propagating, these charges reverse. And you're going to get this propagation along the myocyte with channels opening and creating a reversal in the charge polarity. Now, there's a direction in which the polarization is moving, right? There's a direction. And there's also a charge which is additive. So if you add together a bunch of cells, the charge is higher than a single cell. And you end up with these electrical currents that are recorded from the skin and that illustrate the electrical activity in the heart. When cells are repolarizing, you get that reversal, and again, the charge has a direction and an amplitude that you can measure. When the myocytes are at rest and neither depolarizing nor repolarizing, no current is flowing, and you get the baseline. And finally, if you have positive charges that are flowing towards a positive electrode that is taped to or strapped to the skin, you see an upward deflection on the EKG. To understand the EKG, you have to kind of have an idea of where the electrodes are, what the electrodes are, and what exactly we're trying to measure. So in general, we have 3 leads. One of them attached more or less to the left arm, it might be the left shoulder. One to the right arm, might be the right shoulder, and one to the left leg. Okay, and the left arm and left leg are both positive electrodes. The right arm electrode is a negative electrode. The direction that a current is flowing on the skin determines the deflection. And if you have current flowing towards a positive charge flowing towards a positive electrode, you get a positive deflection of the EKG. One of the things to know about EKG paper is that it is standardized, and each small box represents 0.04 or 400ths of a second, and 5 of those boxes, there's usually a bolder line, represents 1/5 of a second, 0.2 seconds. Also, the vertical boxes represent millivolts, or actually tenths of millivolts. Now, In addition to the standard limbs, we call these bipolar limb leads. So we have a right arm to left arm, which is from a negative to a positive, and we're looking for movement in that direction. A positive charge flowing in that direction will cause a positive deflection. We have lead 2, which represents movement from the right arm to the left leg. And again, the left leg is a positive, and so a current flowing inferiorly from the right to the left is going to deflect. A positive current is going to deflect the EKG in a positive direction. And we have lead 3, in which the left arm becomes a negative, and the right and the left leg is still positive. Okay, and so again, this would be flowing down from the left arm to the left leg. There are also something called augmented unipolar limb leads, and all of these measure electrical activity in the frontal plane. So the bipolar limb leads are lead 1, 2, and 3, and the augmented limb leads are AVR, AVL, and AVF, which add together two of the electrodes to be the kind of the direction that current is flowing. And we plot this all out on something called Einthoven's triangle. And Einthoven's triangle, imagine that this is the right arm, this is the left arm, this is the left leg, this is lead 1, this is lead 2, this is lead 3. Okay, these two added together going in this direction are AVL. These two added together going in this direction are AVR. And these two added together going in this direction are AVF. We put a little clock in the middle and we make 0 degrees pointing to the left, 180 degrees to the right, 90 degrees down, and minus 90 up. And these allow us to determine the direction of the flow of charges. Now, we're not going to go into a lot more detail or really any more detail until you get to your EKG class next semester. I will say that the more you understand about EKGs before you get to cardiology, the happier you will be when you are taking cardiology. That there are books for self-teaching EKG interpretation. The Dubin book, Rapid Interpretation of EKGs, is an old chestnut, and I find it still helpful to this day. So find yourself a book, teach yourself something about EKGs in your spare time, because I promise you, you won't have spare time next semester. You think you don't this semester, but you really won't next semester. So this is a 12 lead EKG. And in the frontal plane, we have lead 1, lead 2, lead 3, and we have AVR, AVL, and AVF. In addition, there are 6 chest leads that are in sort of a horizontal, a different orientation. They're not in the frontal plane. V1, V2, V3, V4, V5, and V6. And these electrodes are located on the chest wall. And this is usually V1 and V2 are a little higher, but basically they're in a horizontal direction. So they're measuring impulses in a in the direction kind of in a horizontal plane. In general, the movement of charge in the heart from negative to positive is directed from the great vessels, the pulmonary artery and aorta, at the base of the heart, to the apex, the tip of the ventricle. And leads that are closer to the base are going to have negative deflections. I'm sorry, electrodes that are close to the base tend to have negative deflections, and this is the base. So V1 and V2 are going to be a little bit more negative. And electrodes that are nearer to the apex are going to have positive. And let's go back and look at that. If you look at V1 and V2, there's not as much positive charge in the QRS complex, and as you get out laterally closer to the apex, the charges are positive. The deflections are positive, not negative. So what do we learn from an EKG? Why do we do EKGs? Well, there is a ton we can learn from an EKG. And I'm going to talk primarily right now about what we learn from a single lead, and we usually use lead 2, and let's back up. And lead 2 is this lead from the right arm to the left leg, from the top to the bottom, from a negative to a positive, because we often get a very clear, normal looking EKG in lead 2 with a P wave, a QRS complex, and a T wave. So you can get the rate, and you do that by measuring the distance, the time between two QRS complexes. And there are a lot of different ways to do that, but remember that each little box is 0.04 seconds, and 5 little boxes is a fifth of a second, which means 25 little boxes are a whole second. And so we can figure out, I'm sorry, I'm going to have to come back to that. 5 boxes are a whole second. But you can use the boxes to figure out the time between one QRS and the next. You can figure out the rhythm, and you can tell whether the rhythm is regular or irregular. You can often tell whether the rhythm is generated by the SA node or somewhere else. Because if you don't have a normal P wave, or you have a very short interval between the P wave and the QRS complex, or the P wave appears to be hidden in the QRS complex, or even during the interval, the ST interval, it suggests that the pacemaker is somewhere else and the atria are not contracting before the ventricles. And you can tell something about the speed of the conduction of the electrical impulses through the conduction system in the muscle by measuring intervals. Using multiple leads, there are a lot of other things we can figure out. There's something called axis, which is sort of the additive direction of charge from heart muscle, and we plot that on this Einthoven's triangle. And a normal axis is usually between 0 and 90. It's in this direction. So if the axis is abnormal, it might tell us something. We can tell if chambers are enlarged. So an increase in the amplitude of, for instance, QRS complexes might suggest that the left or the right ventricle is enlarged, depending on where you see it. An increase in the amplitude of the P wave might suggest atrial enlargement. There are things that happen on an EKG when cells die, and there are acute things that happen, and there are things that are permanent. And so you can see evidence of cell death or infarction, either currently happening, recent, or remote. And then there are some other things. When potassium is high or low, it can be reflected in changes on the EKG. Some drugs have effects that are reflected on the EKG, digitalis, digoxin being a common one. So let's just look at a couple of rhythm strips, which should be lead 2. And again here you remember we have small boxes and big boxes, and the small boxes are 0.04 seconds and the big boxes are 0.2 seconds, and because 5 little boxes, 0.4 times 5 is 0.2, and 0.2 times 5 is 1, and so 5 big boxes is a second. All right, so using that, it looks to me like the rate here is a sinus rate. We have just under a second. We have 4/5 of a second between one QRS and the next QRS, and that suggests that the rate is 75. If we had 5 boxes, it would be 60 because these 5 boxes are a second. If we had 1 box, it would be 300 because it's a fifth of a second. If we had 2 boxes, it would be 150. If we had 3 boxes, it would be 100. If we had 4 boxes, it would be 75. If we had 5 boxes, it would be 60. If we had 6 boxes, it would be 50. After that, it gets a little harder to do the math. Okay. So if the rate here is 75, and if there are normal P waves, we know it's a sinus rhythm. Okay, so we have determined rate and rhythm. Here we're looking at lead 2, and things look different. So there are a couple things that are different. One is that from the peak of one QRS complex to the peak of the next is about 2 boxes, which makes this rate somewhere in the neighborhood of 150. We could count out more. So let's count out 5 seconds. 1, 2, 3, 4, 5. And we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 QRS complexes in 5 seconds. And 12 times 14 would be something in excess of 150. Okay, also, I don't see P waves. I don't see normal QRS complexes. And this is a rhythm we call ventricular tachycardia. So instead of P waves being the pacemaker, something has happened to trigger rapid depolarizations in the ventricles that are not kind of following the rules of refractory periods and so forth. Something called re-excitation happens and you get ventricular tachycardia. And again, we can see rate and rhythm. Here we have back to normal, nice QRS complexes. But there's something funny with the baseline. And this baseline is extremely wavery. And it's wavery in an irregular way. And I can't find any well-defined P waves. Like there are things that could be P waves, but they're all a little different and they're at different intervals. The other thing that's interesting here is that between each 2 QRS complexes is a different amount of time. There's just nothing stable. Okay, here we have a little under 4, here we have 2.5 maybe, here we have a little more than 3, here we have a little less than 3, right? Here we have a whole bunch, 1, 2, 3, 4, here we have more than 5. So this is irregular, and it's not just irregular, it's irregularly irregular. And with that fluctuating baseline and an irregularly irregular rhythm. This is characteristic of atrial fibrillation. So these atria are not contracting in any normal way. Only kind of random impulses are making it past the AV node to cause ventricular repolarization. And so we have an irregular ventricular rate. Now, remember that I said sometimes other pacemakers take over and they're always slower. So this is a rhythm strip, a lead 2 rhythm strip, in which the rate is extremely slow. So let's count boxes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. And so this is a rate of about 30, I believe. Yep. So there is only an impulse every 2 seconds. There's a beat every 2 seconds, a heart rate of 30. Now, I'm looking for P wave. Where's my P wave? I don't see a P wave. But what's this little droop here? Is that ischemia? And it occurs exactly the same in every beat. And so what's going on here is that this P wave is occurring after ventricular depolarization. And this pacemaker is being generated somewhere down the His bundle and and then having to go back up to cause atrial repolarization. So the P wave is here hidden in the ST interval. And the rate is very slow. Okay, this is not something that I expect you to understand right now, but I mentioned something called axis, and we use a concept called vectors to determine axis. The axis is a mean vector of electrical charges. And gives us a direction of the net flow of electrical charges. And the mean of all those electrical charges is dependent on things like how thick the ventricular wall is, which increases voltage, or areas of cell death that result in no voltage from a particular part of the heart, or a blockage to the flow of voltage, which can result in abnormal direction, abnormal vectors of the direction of the electrical activity. So again, a normal axis is in this quadrant. It's between -30 and +90. And here we're showing vectors from atrial polarization, from septal polarization, from ventricular depolarization, all added up together, ending up kind of pointing down in this direction, maybe +60. And you can ignore this slide. You'll come back to this in EKG. But there are some tricks to figuring out what the axis is. And the main one is that if you look at lead 1 and lead AVF and they're both positive, then you know that the QRS axis is in this quadrant. And there are other patterns. If they're both negative, the QRS axis is in this direction. I mentioned that you can learn about the ventricular wall thickness, or the size of the ventricles. So there actually are EKG criteria for diagnosing left ventricular hypertrophy. Obviously, imaging is helpful, but before you get to imaging, an EKG, which is a simple, non-invasive, cheap study, gives you a ton of information. And if you have certain criteria on EKG, big ones being the size of the QRS deflection in the limb leads and in the chest leads, you may diagnose left ventricular hypertrophy. There are others. And here we have a heart where in leads 2 and 3 you can see huge positive deflections, and same thing in the chest leads. So these are much bigger deflections than you would get in a normal heart. And without going into details, this EKG meets the criteria for left ventricular hypertrophy. I did mention that you can learn something about the speed of conduction through heart muscle and the conduction system. And this is an interesting EKG that illustrates a particular problem with conduction speed. Here we have a P wave and a QRS complex. From the beginning of the P wave to the beginning of the QRS complex is just about 5 little boxes, right? At the next beat, 1, 2, 3, it's closer to 7 or 8 little boxes. And at the next one, we're up to about 9 little boxes. And that beat happens, and then you get a P wave, and you don't get a following QRS complex. This is a kind of heart block that's called Wenckebach, where the conduction of the atrial impulse to the ventricles is not working very well, and in fact at some points is not working at all. So you get this gradually lengthening PR interval followed by periodic losses of QRS complexes. If you look at this, it looks irregular, but it's regularly irregular. You have normal intervals between QRS complexes followed by a skipped one, and then go back to the same pattern you had before. And I said that you could see cell death or cell ischemia. And this is a crappy EKG. I apologize, or at least a crappy image, but it shows something that is an indicator of an acute ST segment MI, which is called a STEMI. And this is a great increase in the ST interval. The ST interval should be at the same at isoelectric. It should be at baseline. It is elevated, so we have elevated ST segments, and in the chest leads they look like tombstones, and so this is an indication of a severe ST elevation MI or STEMI, which is a transmural, a through-the-wall cell death event from ischemia, and potentially deadly because the ischemia and the cell death can lead to arrhythmias, as well as to damage to the ability of the heart as a pump. So this is a pattern you need to memorize and never miss.